It's the 17th of September, 2021. This is the RheumNow podcast, and I'm Dr. Jack Cush, executive editor of RheumNow.com. COVID numbers, are they assuring or not so assuring? And the benefits of masking. Smartphones and diets. It was only a matter of time before we get around to that. And the important question in this week's podcast, do more drugs mean more switching, less persistence, patient adherence? Does it go up or down? We're going to discuss that and more. But first, let's begin with a meta-analysis regarding alopecia areata. I treat alopecia areata usually as an accompaniment to autoimmune disorders. And I also treat patients who've had alopecia universalis, very severe. Why do they come to me? I'm not a dermatologist, but I've got the drugs that seem to manage well here, and that is the JAK inhibitors. So we have recently reported on the control clinical trials in baricitinib, 110 patients. It ended up looking good. The primary outcome measure there is a SALT 50 response rate. Recent publication just came out about a meta-analysis, 12 studies, 346 patients with alopecia areata. These studies were done in patients receiving either tofacitinib or ruxolitinib, the other JAK inhibitor that's used for hematologic indications like myelofibrosis. And when they used these in patients with alopecia areata, the success rate was good. The SALT 50 response rate was 66%, as high as like 72%. Turns out it didn't matter if the patient was old, male, female, young. It seemed to work in all groups and also in all different subtypes of alopecia. So I think that's important. This particular report, Dermatology Journal, was sort of focused on a moderate, maybe higher than what they're used to, amount of side effects and risk of infection. But I thought the telltale take-home message was if you stop the JAK inhibitor, well, then the alopecia areata recurs within 3 months in 3/4 of patients. And that's kind of mirrors my experience when I've used these drugs and had to stop them for pregnancy or insurance wouldn't cover it. Yeah, it was about 2 months, 3 months before their skin got worse. Speaking of skin, let's go to herpes zoster. I found this a very bothersome report. It's about the risk of zoster in adults who are taking our drugs, biologics, DMARDs, even Cytoxan and other cytotoxics. It's a sort of a large population-based study, 200,000+ patients, 1.8 million patient years of follow-up. There's a lot of patients, a lot of years, a lot of drugs. The risk of developing zoster was higher in patients who were taking biologic DMARDs and Cytoxan. I think I can kind of expect that. I previously reported that even TNF inhibitors are higher. We know JAK inhibitors are the highest. Cytoxan's not far behind. We know that probably anifrolumab will be high because it inhibits alpha interferon. But in this report, they actually earmarked azathioprine and hydroxychloroquine, like a 20 to 50% higher risk of zoster if you're on those drugs. What's up with that? I wouldn't have said that was the case. They said not an increased risk with monotherapy use of methotrexate, sulfasalazine, or leflunomide. So big numbers. Why is azathioprine and hydroxychloroquine? Is that because they're in combination, reflecting the difficulty of the patient? It's really the patient. I don't really know, but I found those numbers, this take-home message a little bothersome. But the data is the data, and you got to live with that and beware of that. MMWR reported about the risk of what's going on right now during the Delta variant era. If you've been vaccinated against COVID-19 in this era, you have a 5-fold reduced risk of COVID infection. You've got a 10-fold reduced risk of COVID hospitalization and a 10-fold reduced risk of COVID death. Meaning that if you're not vaccinated, then those things are 5 and 10 times higher. Another interesting report from MMWR also came out, a study of 265 students who were COVID test positive, and they looked at their contacts. This is a contact tracing study of 378 close contacts, and they showed what the infection rates were like amongst those close contacts if they were not vaccinated, but if they were wearing a mask or not wearing a mask. So it turns out that the positive patient was wearing a mask and the close contact was wearing a mask. The risk of future COVID infection was 7.7%. But when masks were not used, the risk rose fivefold higher to a rate of 32%. So those of who have to deal with the naysayers who say masking doesn't really work, it's a pipe dream. Well, there is a lot of good data that comes up looking just like this. So masking reduces risk fivefold, or being unmasked increases your risk of infection fivefold. And then I thought this was really interesting from a GI journal, the effect of diet on COVID outcomes. Well, they have a sort of interesting study. It's a really large smartphone study of like a bazillion people on smartphones. And in this large cohort, there were 31,000 people who developed COVID. And in this smartphone study, they were measuring a lot of things, including diets. And they quantified diet and its healthiness and how its quality in several different ways. But the bottom line is that when you had a poor diet, when you were in the lowest quartile of the diet scores, you had the lowest quartile was actually the better diet. You had a 9% lower risk of developing COVID in the future. But more importantly, if you had a healthier diet, good diet quality, look at the paper to figure out what that is, you had a 41% lower risk of developing severe COVID. So there are a number of people out there who feel that they're protected because they're healthy and that they're very healthy in their diet and in their lifestyle. Kudos to them. I think that they are protecting themselves. I think it's one of many ways we can protect ourselves and advise our patients to protect themselves. Another really interesting study about COVID this week. Probenecid, and again, the urate lowering drug Probenecid, not used very much. It works by being an O3 inhibitor and its effects on the tubules. It's been shown in animal models to do several things. It inhibits RNA viruses prior to COVID, influenza and RSV. We know in animal models it also decreases ACE2 expression, highly important in the virus gaining access to the cell through the ACE2 receptor. And then actually in animal studies, mice studies, it's been shown to inhibit SARS-CoV-2 viral replication. So interesting, yet another gout drug is a potential future therapy for patients with COVID, joining, of course, colchicine. And I think that Probenecid and colchicine would not be great therapies for people who are hospitalized and severe, but instead for people who are outpatient and just newly diagnosed. That study needs to be done. This is all animal study data. Speaking of animals, a big giant, a gorilla in the field of rheumatology, that's right, Phil Mease, my good buddy Phil Mease. He actually authored a nice study from CORRONA, that very large registry with, CORRONA is like the sign at McDonald's. Every time you look at them, the numbers keep going up and up. Now they no longer publish their numbers because they're well over 50,000 patients. They could be 100,000 patients or 3 billion for all I know, but they're highly effective in getting patient data that's relevant to practice. Phil and colleagues published the results of the CORRONA registry looking at a cohort, I want to say it was 8,000 plus patients. Maybe I got that wrong, but it's a large number of patients. And they showed in different time eras, starting back in 2004, going to current day, they showed that there's an increasing amount of DMARD and biologic switching, and that time on drug has gone down over time. This is a little worrisome because that basically is persistence and adherence. And those are the things we'd like to see in our patients, but this study says we're not seeing so much of it. Now, again, they report the data is the data, and up to you to figure that out. It could be that these findings reflect eras and the changes in more treatment options. The more treatment options you have, the more drug changes you may make. Also, that if people I volunteered the option of treat to target. If doctors are practicing treat to target, maybe that makes them change more, although I don't think many of us are truly practicing treat to target on a regular basis. We say we do, but in the strictest of sense, we are not. That's another story. Interestingly, got a nice comment from Bobo Tanner from Nashville. Bobo talks about his experience in their healthcare system where they looked at over 700 patients. And in their healthcare system, they have an integrated specialty pharmacy run by PharmDs. And they have shown in their system that by using their own specialty pharmacy, they have better patient adherence to these drugs, better persistence on these drugs, and lower rates of switching and cycling. So that's sort of the flip side to this story. If you look at just what's going on out in the real world, I think Corona accurately reflects what's going on in the real world. Bobo's world, we should all be like Dr. Tanner and the world he lives in. Push for it at your center where you work. An interesting study came out that in the beginning of the week that we talked about systemic sclerosis patients and the need for acute hospitalizations. The bottom line I put out was that there was a significant minority of patients who undergo acute hospitalizations, and there's a mortality associated with that. Thankfully, it's a low number, but it is there, and it's often linked to heart disease and scleroderma, systemic sclerosis-associated lung disease. And if you look at the reasons for hospitalization, infectious disease led the way, 27%, followed by cardiac disease, 16%, followed by digital ulcers and vascular disease, 13%, pulmonary hypertension, 10%, and ILD, 9%. Amongst infectious disease, the most common one, 70% pneumonia. And of the ones with pneumonia, 74% had scleroderma-associated ILD. When you looked at those who died, the most common reasons were pneumonia, heart failure, cancer, pulmonary hypertension, and ILD. So littered amongst all of this is a lot of lung disease, whether it's pulmonary hypertension or ILD or infectious pneumonia. These are all bad players in systemic sclerosis patients. Interestingly, when they looked at in this cohort of, I want to say it was 70 patients, 57 patients, somewhere in there, the multivariate analysis showed that the predictors of acute hospitalization admission were, number one, digital ulcers. Number two, LV dysfunction. Digital ulcers are 6-fold increased risk. LV dysfunction is 7-fold increased risk. Pretty interesting. So we're going to end with a number of cases from Backtalk, or what I'm now going to call cases and questions. I want to first highlight a question that I got from a colleague here in Dallas, Dr. Aleco Barbosa, who says, do you have any inside info on the vaccines for COVID-19 and their use during pregnancy? She points out that last week's observational study from New England Journal may not have had a great control group. So I do think that patients who are pregnant should be encouraged to get the COVID vaccine. And that's just my impression. But the CDC has kind of waffled on that, but come out endorsing what the ACOG, the American Academy of Obstetricians and Gynecologists, what they have said. But there's a new statement that just came out just a few months ago from ACOG and the Society for Maternal Fetal Medicine, where they basically encourage their members, OBGYNs and whatnot, to enthusiastically recommend vaccination to their patients. And why, you say? Certainly there are no studies. As you remember, last week in the podcast, we talked about 2 studies showing that there's no increased risk of spontaneous abortion, no significant increased risk of spontaneous abortion in pregnant women who have received the COVID-19 vaccines, usually mRNA vaccines. And the reason that they're endorsing it strongly is, number one, pregnant women who get COVID do not do well. They actually do quite poorly. Secondly, things are getting worse in this era of the Delta variant. And they also say that yet only about 22% of pregnant women have received 1 or more doses of the COVID-19 vaccines, according to the CDC. So they are firmly on the side of making sure that the pregnant women, unless there's a contraindication, that they go ahead and get a vaccination. Our next back talk comes from Dr. Eve Skopolidis in New Orleans.
Hi, this is Eve Skopolidis from New Orleans. I'd like to ask about how to treat a woman who's had a spiral fracture on a bisphosphonate and is now completing her 2-year course of teriparatide. What is the next step? Is it advisable to restart, go back on a bisphosphonate, or is there another option available?
Thanks, Dr. Skopolidis. I think that's a really good question. I have my initial response was, no, don't go back on the bisphosphonate. I mean, the patient got into trouble on bisphosphonate. But I don't trust myself on osteoporosis, so I called two of my friends. I called Dr. Catherine Dow, my partner, who teaches me about osteoporosis, and Dr. Nancy Lane, who's taught me about osteoporosis for many years. Nancy said, Dr. Lane at UC Davis said, you could go back on bisphosphonate. Depends on how many years she's been on it. But really, it depends on where she is right now. So at the end of 2 years of teriparatide, Forteo, you should probably repeat the bone mineral density and see if she's gotten much, much better. If she has, it might be okay to go back to a bisphosphonate. Dr. Dow says if you're going to use a bisphosphonate, she'd go to IV zoledronic acid or Reclast. But again, there needs to be a good reason to do so and not the many reasons to not do so. I mean, she's, again, having a spiral fracture is sort of not a good idea. The options here, if the patient has sort of held steady on her BMD, then your options are to choose alternative therapies. And the two that came up amongst my consultants were my first choice, denosumab, which seems to be an easy answer for a lot of patients. And if not denosumab, then you could consider Evenity or romosozumab. Now, the problem with romosozumab is that that it has a 1-year limit and it has a box warning against risk of myocardial infarction and whatnot in patients who are high-risk cardiac patients. And it's got a 1-year limit. We know that Forteo's got a 2-year limit because of the risk of osteosarcoma. But wait, no. Nancy Lane says that's been removed. That box warning has been removed because long-term studies of patients on Forteo say there really weren't any cases of osteosarcoma in humans taking that. That was seen in rats. So maybe you could continue the Forteo. How long, we don't know, but you could continue it for a while until you make another choice to either choose Prolia or romosozumab. But you do have several options to cycle beyond those two. So thank you, Dr. Skopolidis. Another call from Dr. Sharp.
Are many of you having problems getting tocilizumab? There seems to be a shortage, and if you can get it, where are you getting it?
So the tocilizumab shortage is the IV tocilizumab shortage, and of course it's because of its rapid and frequent use as therapy in patients who are hospitalized with severe COVID-19 infection. The shortage was primarily felt early on in Europe and I believe in Australia, and then has somewhat crept into the United States being a shortage, but it seems to be very spotty. A number of people I spoke to this week said that they haven't really had a problem. In places where there has been a problem getting IV tocilizumab, you always have the option of using either sub-Q tocilizumab or changing to sarilumab, the other IL-6 inhibitor. And more recently, the manufacturer has come up with its statement on that, and that's going to be a link in there. But they updated their website to say on September the 3rd that they have begun to replenish the U.S. supply of Actemra and anticipate that will be in full supply by the end of August. But it's hard to predict what the future use and the future, because it's based on the growth of this fourth surge of COVID. And so they're going to try to keep up with the unusual pace that's been driven by the pandemic. So again, I think maybe the answer to your question is to talk to your colleagues about what they're doing, and then also to talk to your sales reps to find out what they can tell you about the supply being replenished. Our last call comes from Munir Ahmad.
Hi, Dr. Cush. This is Munir from Springfield, Massachusetts. I have a 40-year-old lady who underwent kidney transplant in 2006 for focal segmental glomerulosclerosis secondary to pregnancy. She is maintained on Cellcept and Platacept and presents to me with a 3-year history of polyarthritis involving small and large joints. She was managed by orthopedics with intermittent steroid injections in various joints over the last 3 years. How would you manage this patient going forward?
Munir, very challenging case. I've seen several of these. You don't find chapters on this sort of thing. And I'm not sure I heard you right. I couldn't make it out. The patient's on mycophenolate and another sept. Was that abatacept? Anyway, it's not going to change my story, my answer here. Renal transplant patients can get arthritis, and they can get polyarthritis. The first thing you need to, I want to remind the audience of is serologies are wildly inaccurate in renal failure patients and patients who undergone transplant. ANAs, rheumatoid factors, even CCPs abound, and don't be swayed into thinking this is lupus RA unless they otherwise meet criteria for lupus or RA. Similarly, uric acid levels go up and there's a high risk of gout and crystal arthritis in these patients. So at the top of the list, causes of polyarthritis would be gout. Yes, gout, not just oligo or monoarthritis, but these patients do get polyarthritis that can be due to gout. Similarly, they can also get calcium pyrophosphate deposition disease. So joint taps might be important here. Next highest on the list is going to be the risk of infection. Common infection, septic arthritis, but also bizarro opportunistic infections, anything from MAI to chikungunya to, bacterial species that you don't know how to spell and have never heard of. These happen very frequently in this cohort. They are very immunosuppressed and should be considered as such. They should be tested for Hep B and Hep C, because that happens here as well. And that's like the main thing. The risk of developing RA or PSA or another well-identified inflammatory polyarthropathy doesn't exist in the literature. There certainly could be complications of steroid therapy or other immunosuppressives that might relate to musculoskeletal disease like AVN, etc. But really, crystals and infection, and then there is this thing where you don't prove crystals or infection, and they have a polyarthritis. And what I've done in the past is I treat them as if they're a seronegative RA, where I always worry about the diagnosis and what's underlying this, but I treat what they have. Meaning I'll use the drugs I usually use as long as they're not contraindicated in someone who's had renal transplant and taking the drugs that you mentioned. So I would use other biologics. I would use methotrexate and maybe even leflunomide. A lot of talk about use of JAK inhibitors in these renal transplant patients for their transplant. That could also help their arthritis. But again, if you're going to treat this as if it's seronegative RA, you have to worry at every visit. What am I missing here? And you have to be liberal in tapping joints where you can get fluid to test for infection and or crystals. That's it for this week on the podcast. Hope you enjoyed this. Stay safe, wear your mask, encourage your patients to do so. Listen up.